Imagine the outer edges of the world slowly fading to gray, or a persistent blur taking over the center of your sight. For a patient experiencing progressive vision loss, the primary symptom is often a sense of the world gradually disappearing. For the clinician, however, that symptom starts a specific diagnostic clock. The presentation of progressive vision loss necessitates immediate categorization to ensure the correct path of care. There are two distinctly different clinical tracks: inherited retinal diseases, which are genetic, versus age-related macular degeneration, which is acquired. The IRD pathway relies on a rigorous analysis of systemic history and detailed genetic investigation to identify the underlying mutation. Conversely, the AMD pathway is navigated through localized structural imaging and the modification of specific lifestyle factors. Simply monitoring retinal dystrophies as they progress is no longer the standard of care. Modern management requires an active, multidisciplinary approach to maintain the patient's functional vision and quality of life. The terminal goal of these diagnostic tracks is to qualify patients for emerging targeted therapies or to facilitate enrollment in active clinical trials. Differentiating between an IRD and AMD early in the presentation determines the patient's access to treatment and their overall life trajectory. The most critical decision point in the diagnostic process occurs during the initial history taking. On the IRD track, the focus is on the exact age of onset and any history of clumsiness or mobility issues, which can indicate early peripheral field loss. Hearing loss is a diagnostic indicator for Usher syndrome, an autosomal recessive condition that links auditory deficits with progressive vision loss. Clinicians must also check for the presence of extra digits, as polydactyly is a hallmark finding for Bardet-Biedl syndrome. The AMD history focuses on the character of the blurry patch in the central vision. Sudden onset typically points toward neovascular AMD, while a gradual decline suggests a different stage of the disease. Patients with AMD frequently report specific functional difficulties, such as trouble reading small print or challenges driving at night. Finally, we must account for family history and current smoking status, both of which are significant risk modifiers for the progression of AMD. Retinal disease is rarely a purely ocular issue. These non-ocular findings form the first definitive branch in the diagnostic process. While visual acuity and standard field tests establish a baseline, targeted multimodal imaging provides the objective data required for a definitive diagnosis. In rod cone dystrophies, fundus imaging typically reveals classic bone spicule pigmentation, often concentrated in the mid-periphery. For daughters or mothers of patients with X-linked conditions, fundus autofluorescence, or AAF, is essential to determine carrier status. Clinicians must differentiate between a coarse and a fine modeling phenotype on the AAF imaging of these carriers. Carriers exhibiting these fine or coarse phenotypes are statistically less likely to experience rapid vision loss compared to other presentations. On the AMD track, the focus shifts to the interpretation of OCT cross-sections to identify localized structural changes. These OCT scans help differentiate standard sub-RPE drusen from subretinal drusenoid deposits, also known as reticular pseudodrusen. Fundus exams allow us to stage the disease, distinguishing intermediate AMD, characterized by large drusen, from late-stage AMD, marked by geographic atrophy. Clinicians must remember that the overall AMD classification for the patient is determined by the presentation in the worst-performing eye. Precise phenotyping does more than just name a disease. It maps out the expected progression and allows for a more accurate discussion of emotional and functional expectations. A confirmed diagnosis dictates a specific management trajectory. The IRD pathway requires a mandatory referral for genetic testing and counseling to identify the specific genetic drivers of the condition. Syndromic cases necessitate ongoing co-management with audiologists to address auditory health in conjunction with vision loss. Clinicians should also facilitate referrals to counseling services to help patients and carriers navigate family planning and the psychological impact of inherited disease. Management often culminates in a referral to clinical trials, such as the NACUITY trial for retinitis pigmentosa or targeted Usher syndrome trials. For AMD, a management focus is on lifestyle modification and localized monitoring. This includes regular home monitoring with Amsler grits and the initiation of AREDS nutritional supplementation. Reinforcing the importance of a healthy diet and absolute smoking cessation is critical to slowing the rate of degeneration. Advanced pharmacological options, such as pegcetacoplan, are now available for managing late-stage geographic atrophy. Furthermore, patients may be eligible for cutting-edge gene therapy clinical trials, such as the gyroscope trial currently being conducted at Sarah. The clinician's role is to act as the central hub, connecting the patient to this vast network of specialized multidisciplinary care. This unified model places the clinician at the center of modern retinal care workflows. For IRDs, the clinician provides the systemic perspective and genetic rigor required to identify the disease. For AMD, the focus is on precise structural imaging and active management of lifestyle risks. In both cases, the specific phenotype, whether identified through OCT findings or AAF modeling, dictates the timeline of care. Psychological support remains a constant necessity, particularly for carriers who are managing the heavy complexities of genetic inheritance. Clinical trials have become accessible endpoints that depend on accurate and timely referrals from primary care providers. By applying this divergent diagnostic logic, clinicians ensure patients with progressive retinal disease are moved beyond simple observation and onto the appropriate therapeutic pathway.